to step out of the substance abuse field, and I ended up back here again. Part of kind of just a brief announcement for the HRSA program is I had substantial student loans when I finished my PhD, and part of it was from my master's degree that I earned in 2001. And there is a federal program out there, which is what brings me to where I'm at. I am the director of the substance abuse program for the Crow tribe in Crow Agency, Montana right now. And this program that I'm working for meets the service criteria for my student loan service agreement. So in exchange for them paying off my student loans, I am doing my service here, but I'm really loving it. I'm really enjoying working here with the people. I'm close to home, so I can run home whenever I want, and or my family can come here. So it's been a nice transition for me. And this harm reduction is really popping up all over Indian country now, because the opioid epidemic has really hit Indian country during the COVID, and it continues to be a serious problem. And so that's what we're going to be talking about today. I really appreciate you guys taking time to attend this presentation, and I hope you get some helpful information that will help you to help all of us address this issue throughout Indian country. So we can go on ahead and get started. I want to move on to the first slide.
I'm ready when you are, Avis.
Go ahead.
Okay.
We are ready to rock and roll. Okay, the objectives we will be covering today, we will do an overview of the harm reduction, look at our culture and our value systems, look at some historical approaches to addressing drug use, discuss harm reduction ideas, look at some harm reduction intervention models. I was real surprised how many actually are in existence. Address opioid use in our tribal communities, look at overdose prevention, which is harm reduction in itself, and share some resources at the end. A lot of this harm reduction material that I was finding as I began my research on this topic really focused on intervention with the HIV risk. And of course, drug use is involved in that. So looking at the risk for HIV, unprotected sex is involved. It can also be passed from the mother to the child, and using syringes. And the needle people that are IV drug users is where this is like the most problematic. So that is why there's so much emphasis, not only just on the opioid epidemic, but also the HIV in combination, that those two kind of go hand in hand. We can go to the next slide. Also, quite common among IV drug users is hepatitis transmission. There's hepatitis A, which is also involves sexual contact, and most of the times it's with an IV drug user. Hepatitis B, contact with infectious blood, again, sexual contact and sharing injection equipment. You know, some people share their needles, and that's real important that they don't share them. And part of this harm reduction is a movement to provide some intervention there. And hepatitis C, contact with blood primarily through sharing syringes and other injection equipment. And then we look at our value systems and talking about what brings us to this work, like what values guide your work? What brings you to this work? Does this line up with your beliefs in your life, and what brings you here? And I share with people, when I first decided to step into the substance abuse profession, it was mainly because I grew up in a home environment where alcohol was a big problem. You know, I didn't know much about drugs until I believe I finished my master's degree in 2001, and I was running the first drug court on my reservation. I was the coordinator of that. And my phone was ringing off the hook at my office, and it was methamphetamine. Almost every single phone call that was coming in was, concerns about meth, how to help, what can they do, where can people go? And I was like, oh my God, they didn't teach me that, So that was when the methamphetamine epidemic hit our reservation pretty hard. And now we're dealing with the opioid crisis. So really looking on what brings us to this work. And as Natives, most of us go to school and get education because we want to help our people in some way. So for me, like I said, I was going to help people with alcohol, but now it's broadened because of all the problems we have in our tribal communities to look at those other substances. And so really looking at your values, like, is this really in your goal for life, and a desire to help? Because this work is not easy. It's a tough job. We'll go on to the next slide. So again, discussing our values and what guides our work. A lot of us, as our cultural values, as I was talking about, when we go get our education, it's to help our people. So a lot of times I have to, really look at, we're here to help people, and every day, I ask for guidance to help help people that come looking for help every day. So that's a big part of our work and what it does for us. Go to the next slide. Again, looking at our value systems, which occurs on 3 levels. There are external factors that help us develop our values. Sorry, this guy is wanting my attention. It can come from our parents, from our families, and from media, and also our personal experience. Like I was telling you, mine comes from, my life experience of having grown up on the reservation and seeing a lot of alcoholism in my family, and wanting to make a difference, and make my own life different and have my own children's life be different. So those were important values for me. You can go to the next slide. Also, the third one is our obligation as providers. In the counseling profession, we have ethics that guide our work, and that guides our goals. It's incorporated in our mission statements and the programs we work with. It guides our policies and procedures on our day-to-day work and how we carry that out, our job roles, and what's expected of us as we do this work. And to add on to the value systems, coming from an Indigenous point of view, there needs to be a 4th level for Native people, and that is our role in cultural and traditional values. These were, our original instructions. We have, I believe it is our innate nature as Natives to help our people. So coming from cultural values, it's inherent, it's a part of who we are, and we have a lot of tribal specific, ways of conducting our life, living in balance and doing things in a good way, and belief that if you're not living your life right, then obviously your life is not going to go right either. Being grounded in our collective experience. So it is evidence-based that, as communities come together to address these things, it can work. And that our values of culture, it's a gift to us, it's what is our greatest strength for prevention in this work, and to also live in balance with the universe. We as Natives, believe everything has life in it, even things that are still. You can go to the next slide. Since I'm a Arapaho, I always share with people that I always share my perspective of how I do my work, and I'm mindful that there are 567 federally recognized tribes out there, and we all look at things differently. But coming from an Arapaho viewpoint, this consists of our culture. It's just our way of life. Our values are uniquely held and displayed by our people. We believe that the university of all natural objects, animals, plants, trees, rivers, mountains, and rocks, etc., all have souls, are spirits. We believe in the Great Spirit. And as I was thinking about that, you know, my grandfather has our sweat lodge right by the river runs right by it. And, you know, when we look at those rocks, we refer to those rocks in our ceremony as those are our grandfathers when we go in there. Everything has a symbolic representation for us. You can go to the next slide. Several examples of our Indigenous values is looking at our medicine plants. We use sweet sage, cedar, and sweetgrass in a lot of our ceremonies and our day-to-day life. You know, even at my office, we smudge every morning and we pray. Our mobility, walking, running, horses, and we used to have wagons. My grandma used to always remind me that she rode in a covered wagon. We also look at our lives as a journey. So there is a past and there's a future. So we always look at, you know, where are you at on your journey in life? The Arapaho people call it the 4 hills of life. And we look at our relatives. Our kinship is real important. You know, we adopt a lot of people into our families and people adopt us as part of their family. Our songs, our stories. You know, as a Native, I'm a storyteller. So as I do my presentations, I'm full of stories, and it comes from a lot of my experience and my work and my life. We look at our spirituality, and for some it includes religion, that is our healing and curing, and our traditional songs. Our values, the most important value of us is to have respect for ourselves and for other people. We look at our arts. You know, a lot of our crafts that we do, our beading, basketry, contemporary and traditional music. We look at our community, our games. Here in Crow right now, hand games are kicking in. So people are out all hours of the night playing hand games now. And I think that's really something neat because our young people are participating. Our beliefs, harvesting traditional foods and hunting, looking at our language that includes, you know, our songs and ceremony, and we live our life by seasons. We can go on to the next slide. Okay, moving on to the overview of harm reduction. The historical approach to addressing drug use was locating the problem in the person, not in the substance. So it was looking at that person from a moral viewpoint and you know, what is wrong with this person, and looking at the demand reduction. And the next one is locating the problem in the substance. So therefore the war on drugs, and how can we, you know, bust these drug dealers and stop these drugs thinking it's coming from another country when some of the stuff is being manufactured and distributed right here in the United States. And then looking at the harm reduction movement, which looks at the problem between the person and the substance, which changes over time, of course. The definition of harm reduction is a perspective and a set of practical strategies to reduce the negative consequences of drug use, incorporating a spectrum of strategies from safer use to abstinence. So harm reduction can be a gateway to treatment. It can be a way to get them into that treatment door. One historical context, public health policy in Western Europe, out of the epidemics of hepatitis and HIV. So this is where it started with that. And it's still, you know, it's real important that this is here now because it directly ties into the opioid epidemic that involves a lot of injection drug use. Going to the next slide. The main goals of harm reduction is to improve the health and well-being of individuals, their partners, their associates, and of course, our communities, especially our tribal communities. Goals of harm reduction includes preventing disease. The sterile syringe access prevents the spread of HIV and hepatitis C, as well as abscesses and other infections. Having been in this field for as long as I have been, I have seen people come into treatment, especially residential treatment, with some very serious damage done to their bodies from using needles to inject drugs and having to get them some medical help. Over 8,000 people are infected with HIV every year, and this is due to sharing needles and not having clean syringes. About 15,000 are infected with hepatitis C every year, again, due to sharing needles and lack of clean syringes. I also learned in my research on this project that people that have been treated for hepatitis C and get better can get reinfected if they relapse and go back to using again. And I wasn't aware that was something I learned working on this. Go to the next slide. We also want to reduce mortality due to disease and accidental overdose. I believe of people that overdose didn't plan on overdosing. There was just nobody there to help them or intervene. We want to provide access to medical care. Some people don't have transportation to medical care. Injection drug use accounts for about 20% of all HIV in the United States alone. Among women, 61% of AIDS cases are due to drug use and sexual contact with someone who had HIV through injection drug use. So it's that vicious cycle there that causes the spread of that disease. And we also want to provide treatment for drug dependence, the inpatient, outpatient, detox, medication-assisted treatment, sober living, and transitional housing, and also to empower our communities and to really work on reducing the stigma that comes along with the harm reduction and treating opioid epidemic. Some examples of harm reduction are to eating a reduced low-fat, low-carb diet. Everyone's into not eating carbs except for me. I like my bread, and I thought I've been eating it all my life. I'll cut down, but I'm not giving it up. Wearing our seatbelts. You know, we're required to wear our seatbelts. Washing our hands, especially with this COVID. Wearing your mask, using that hand sanitizer, exchanging used syringes for clean syringes, having a medication-assisted treatment program or access to them, having naloxone and Narcan available, and teaching overdose prevention. So a lot of treatment programs here in my community, we're all trained in our office of how to use the Narcan and naloxone for overdose prevention, and also advocating for the rights of drug users. And it is our role. When we talk about harm reduction, you know, a lot of people live life dangerously. You know, my younger brother was a bull rider, and my dad used to think he was really crazy for doing that. And so I'm like, Dad, you know, he's wearing all the safety equipment, you know, he's got his vest on, he's got his helmet on, you know. Some people just like to do dangerous things like skydiving and kayaking and climbing the highest mountains, you know. So, you know, we're not stopping them from doing that. So this is a lot of what harm reduction is how can we help people to be safe and not, you know, enforcing that they adhere to strict abstinence. Some principles to harm reduction is reducing the daily harm one experiences so that individuals can be empowered to make greater changes in their lives. As I was doing research on this project, I listened to, you know, some podcasts and did a lot of research, and it was really good for me to hear people say, when these people came to do their harm reduction approach, that they had no intention of stopping, but just the fact that, like I said, this can be the gateway to treatment, that after they got help for a while in exchanging their needles and, you know, maybe getting something to eat, maybe even getting to take a shower, that they finally, the more they showed up, eventually they got themselves into treatment and stopped. So it might not happen right away, but it shows that eventually some of these people get help. Harm reduction recognizes that there are realities of poverty, racism, classism, sexism, social isolation, a lot of trauma and substance abuse people, and other inequalities that affect their vulnerability to and capacity for effectively dealing with drug-related harm. Harm reduction cessation of drug use does not have to be the first goal of intervention. And Ed Parcellis was going to be on with us today, and he shared with me his personal experience with harm reduction. He was totally against it because it was all, he felt that he has a strong belief his values coincided with complete abstinence. I was first introduced to the term harm reduction in my master's program while I was studying to get my degree as an addictions counselor. And I was quite fascinated with it because I was looking at it from the alcohol perspective. Like, well, what if they drink less often and they drink less and they plan to be safe when they do use alcohol? Because a lot of the bad problems that happen on my reservation, I say 99% of the time when I hear something tragic has happened, I always say to myself, I suppose they were drinking. And a lot of times I'm right. So that was how I looked at harm reduction, is if, we can't get them to completely stop, can we get them to slow down and do less and be careful with it? Abstinence is an excellent form of harm reduction if the client wants to stop. Many clients have made the decision not to stop. And I was running a drug court program in the last job I had before I moved to where I'm at now. And I had several, mainly men, tell me, I'm just in this program doing what I'm doing and I'm not going to stop. When this is all over, I'm going to go back and I'm going to drink again. I'm like, well, what are you going to do differently this time so that you don't end up here again, coming in for treatment? And he just went off of all these things that he was going to do. And I was like, that's a perfect example of harm reduction. And service providers need to meet the clients where they are, not where they would like them to be. And so that's not imposing our values on them. I had a young lady when I filled in for a group a few nights ago say, she was going to go to her birthday party, but not drink and use marijuana. And so sometimes I kind of talk lightly about a marijuana maintenance program. I'm like, well, it's legal here in Montana. So that's like another reality that I'm facing here in my work. So I was like, well, at least this lady is not telling me she's going to go get drunk or she's going to use drugs. And so, we can't tell them they can't. And that was what she was sharing with me. So I just was, talking to her about what were her plans for that and what did that look like. And, it was nice to see her show up again and she like, oh, her party that she was going to go to went really well. Like her plan worked for her. And I was like, okay. And she, she's still back, but that's us meeting them where they are, planning to do outreach in the community where we've got people walking in the streets, not judging them and, offering them help, letting them know that it's there and not forcing them. Harm reduction ensures that our drug users and those with a history of drug use routinely have a real voice in the creation of programs and policies designed to serve them. This sentence right here really made me stop and think about the work that I'm doing here and the programs that I'm implementing and the grants that we're using to provide services to our community. And I'm like, I really need to include more of these people and get more of their input in the work that I'm doing and not just be like, we're just going to make this program, but have some of them come in and be, a part of sharing with us what it is they would really like. Affirms that drug users themselves as the primary agents of reducing drug-related harm and seeks to empower users to share information and support each other in strategies that meet their actual needs. And when I have people that come to our programs, I tell them, you have this information we shared with you today. You can take that and go share that with, your friends, your family. So letting them feel like they're making, maybe helping some other people as they go about their life. Can go on to the next slide. Okay, this is reducing the daily harm one experiences. Individuals can be empowered to make greater changes in their own lives. So I think once they start to use less, they might have more time to think when their minds and systems are clear a little bit to think about changing their own life. It recognizes, this approach recognizes the realism of poverty and isolation. So I've had to share this many times with, working in this reservation where I'm at under Indian Health Services, and they really have a lot of restrictions on how we use our funds. And so I have to look for creative ways to get the funds we need for different things, because some of these people don't have anything to eat at home. I try to make sure we can offer them something when they walk in the door of, a cup of coffee or a bottle of water. I told our staff, I said, we're working now to where we have snacks there. So when we see people, some people come to our office now, and it makes me feel good to know that we're a safe place for them to come to, just to get away from their home environment, but they're coming there to because they're getting away from whatever it is at home, but yet, they're hungry. And some people actually come right out and say, I haven't had anything to eat today. I said, so we need to be prepared for these people that come in. It takes a lot of courage for them just to walk in this place and say that they need help. So for them to say that they're hungry, it really, it was something I felt like we needed to address. So what does harm reduction look like? There are several examples, especially since we've been through this whole COVID thing that we're still going through, wearing your masks and social distancing. If you look at the kitty in the middle there, we've got our animal shelters that have pets that need places to go, having no smoking signs, or like just recently I was asked if I would take a tobacco program, and I was like, sure, it fits perfectly with the work that we're doing here. Wearing eye protection in certain jobs, anything to do to keep yourself safe, like not drinking and driving, and wearing your seatbelt. Just anything you can do to keep yourself safe and your family safe. Again, we want to look back at our native values and how this ties into harm reduction. And as I was thinking about this, I really think that, our values and our way of living really has been from a harm reduction standpoint. It fits perfectly. So, we give back and sharing what we know. We as natives have the responsibility to help ourselves and share what we know with those in our community. And doing education and outreach. I have a couple of young people that work in my program that are in training. So, they are the ones that go to the schools whenever they call for people to come and speak to the adolescent and younger population. Those are the two that I like to rely on. We can go to the next slide. Our cultural values is that of respecting all life. We're not here to judge people. We're here to respect them. We're here to lift them up. We're here to help them. So anyone who uses drugs is someone's mother, father, sister, brother, daughter, son, friend. And so we have to think, how would we want them to be treated if they were getting help? I want them to be treated good so that they feel safe and they want to keep going back and meeting the client where they are at, and not providing any, we want non-judgmental services. So I always remind our people, these people come first. That's why we have this job. This is why we're here. We're here to help them. So we have to make them first. We have our cultural values of helping others. I was taught to share what you have, even if it's all you have. Injection drug users can be stigmatized, judged, vilified, demonized, and ignored, yet they're a part of our family. They're a part of that circle, and it's our responsibility to care for and help our own people who are using those drugs. We have to have compassionate responses to these drug users and drug-related harm so that they feel welcomed and, you know, that they want to come and get our help. And what I'm seeing also as a new trend in my program is these people that are voluntarily coming in for treatment on their own. Nobody sent them to, so it's their own idea to come. And I'm like, I'm seeing more of that. And I'm like, that really makes me feel good that there's people out there that are coming for themselves on their own. We can go to the next slide. The cultural compassion, defined as to suffer together. The feelings you have when witnessing someone suffering and feeling motivated to help. Again, the work that I do, there's a lot of what we call vicarious trauma or secondary trauma, because these people that come in for help have been through a lot of trauma. And sometimes I can tell that it weighs on my staff. And so I have to remind them of self-care, you know, that comes with this job. That's why I say this job that we do, it's hard. It is not easy, and this is probably the hardest part. But when we go through our ceremonies, at least I know from my own viewpoint, we look at like when we go into our ceremonies that involve fasting, you know, or even our sweat lodge, that, you know, some of this stuff it's very intense, but we believe through that it makes us better and it makes us stronger, and that we come out of that strong. And then similarly is empathy, and that's our ability to understand someone suffering from their perspective. So I really love the peer specialists, because I actually have clients say, I like so-and-so because they've been there. They know what it's like. You know, they can really relate to these people that are our peer specialists. So I'm really glad we have those people. So compassion includes the desire to help. That's what we're all here for, and that's why you guys are here today. Some key concepts are cultural values. When we educate ourselves on the health needs of those who use drugs and respond compassionately, we honor our traditions of sharing what we know, helping others, and respecting all life. I oftentimes have to remind myself that a lot of these clients that come in don't read, you know, so it is our job to educate and share information with them. So there is a continuum of use. It all starts out with experimental curiosity. You know, when we look at our data from surveys that are done on our youth in our tribal communities, there's always substance use is popping up there. Right now, I think vaping is a big one for the schools that are contacting us for adolescents. There's social and ritual use, so people use at parties or certain events. There's intermittent use. Some people use on a regular basis. And then there's binge use. When I worked on my reservation, when I did a strategic planning framework, we spent a whole year collecting data to do an epidemiology profile of the substance use problem on our reservation. And the main thing that popped out was binge use among Native Americans. We just happened to be doing our survey at the right time when the census was being done. So we asked, can we throw our questionnaire in your census when you go out and to our tribal community, so we can see, you know, what people's thoughts are and about substance use in our community. So what popped up was binge use. So what that means is a lot of people on my reservation, the Wind River Reservation area, were binge drinkers, that there'll be long periods of time they don't drink, and when they drink a lot. So that was something that stood out for me. I don't know if any more research has been done on that trend. There's substance abuse, and then there's dependence, and then we have severely and persistently chemically dependent and chronic relapse. So I'm seeing very young people coming in cirrhosis, and very young people are dying from cirrhosis. So I'm like, what are we doing about that? How can we help these people? It's really sad when these people are losing their lives at such young ages. Go on to the next slide. So what is injection drug use? HIV and hepatitis C can be transmitted very easily while injecting and sharing syringes. Trace amounts of blood can enter the syringe and remain in the barrel. The environment is ideal for the virus to remain alive for a period of time, largely because of the hermetic seal. So those are like really tight seals on needles and the substances that are being used. Go to the next slide. Intravenous drug use harms. Forgetting to take medication. Many users forget to take their medication. Dependency disorders characterized by ongoing use despite problems that are produced. You know, they could be having legal problems. They could lose their job. They could lose everything, but that they can't give up their substance. Track marks, those from injecting drugs directly into the vein, can cause darkening of the veins due to scarring and toxin buildup. So there's a lot of problems that comes with that. Here's a picture that I found in doing this research of needles, and there's a new needle on the top left quadrant. And then the next one shows a needle to the right that was used once. And if you look very closely, you can see some probably what would be blood on that needle. And then the bottom left is another needle that was used twice. And then there's one on the very bottom quadrant that was used more than once. So, you know, research is showing, you know, we're not enabling these people. These people were already doing this, but we can at least provide them with some safe equipment to reduce those harms. Intravenous drug use harms. Stigma and shame can be experienced from strangers, family, friends, coworkers. Furthermore, social service, healthcare, and drug treatment providers may also stigmatize these people. So we have to really be mindful when we're helping these people. And it's like I said, what brings you here? What are your values? That we're not here to judge people. So looking at the harm reduction intervention models. We can go on to the next slide. The first one is disease prevention. So this one is to reduce the transmission, primary or secondary, through bloodborne pathogens, for example, HIV or hepatitis. Some things that can be done could be syringe service programs, or syringe access programs, and over-the-counter syringe cells. The second one is harm elimination and abstinence. So this is to assist clients in achieving and maintaining abstinence. So this is getting them to stop completely. Used in drug treatment programs. There are some abstinence-based housing programs called dry housing, and dry housing means they do not allow any substances to be used there. They could, you know, lose their spot in the treatment program, and also some mental health programs. Another model is called recovery readiness. This is to work with the clients who are active users of drugs and alcohol to help them achieve abstinence and recovery in a particular time period, usually 3 to 6 months. And these can be applied in damp housing programs and shelters. And damp housing programs and shelters are those programs that do know the people that are staying in those homes and shelters are users, but not allowing those substances to be there in those programs, in those shelters. I mean, they may know, yeah, they're staying here, but while they're there, they're not doing this. But we know they're out there and we're not going to stop them. Applied in mental health programs to address how drug use affects medication adherence. My colleague here just send me a little message here that some people talk about those people or these people. And just recently I had my own staff member, and she's not a direct service person. She's kind of our in-house HR person, and gets a lot of our paperwork ready for the people people that come in for assessments, and she's like, what's fentanyl? You know? So I got online and Googled and printed out a couple sheets. And so we're like, okay, today, you know, every morning we have a meeting. Today we're going to talk about fentanyl. So now she knows what fentanyl is. And I like how Steve just reminded me that some people tend to separate themselves or think less of just the vocabulary that we use. We need to be mindful of that. The other model is moderation and controlled use strategies. This is to reduce the harm by reducing the consumption. Again, like I said, when I first heard harm reduction and was open to it, was looking at the Native people, like even in my own family, well, geez, if they just used less and they didn't, you know, drink as often, and controlling episodes or the situation, like they're going to use only on weekends, like the DUI programs. I always tell them, I'm not here to tell you not to do, but when you do, be careful, you know, have a plan of action ahead of time. Like, are you going to call for a ride, or you're going to be where you're not going to drive for any reason? You know, switching the mode of administration, you know, smoking and not injecting. This can be applied in self-help support groups called moderation management, some syringe service programs, and some housing programs, again, in the damp housing programs. We can go to the next slide. The next one is substitution therapy. The goal is to replace one drug with higher associated risk with another drug of lower risk. Heroin isn't quality controlled. Medication assisted treatment is prescribed by a trained medical provider. So the application called warm turkey is the nicotine replacement strategy. So instead of getting them to quit cold turkey, we can go warm turkey with giving them some patches or some gum until they're ready to go cold turkey. We can go to the next slide. Okay. Okay, the relapse prevention is to prevent the return to drug use following a period of successful abstinence. And I've often shared with the people that I work with, when I tell them they are in successful maintenance, is when they've been clean and sober for an entire year. And then that's when, for me, my perspective is when you use after that time period, that's a relapse. I said, but for me in that year, if you use, that's continued use. You have to establish that solid maintenance period. But, you know, it's a part of the recovery process. You know, I like to let these people know that because they relapse, it doesn't mean, you know, what can we learn from this that you can apply as you go back and get back out there. Applied in drug treatment programs, a lot of outpatient and inpatient as well. You know, I've seen people get out of residential treatment. And I, you know, from my own perspective, anybody that comes to any treatment program, you know, outpatient or residential, and in my viewpoint, there's a 50-50 chance that that person is going to, you know, continue their abstinence and stay in recovery. So the objective there is to understand the high risk behavior and high risk situations. And then there's the overdose prevention to prevent death and negative health consequences. So this is applied in syringe service programs, drug treatment programs, a part of relapse prevention strategies, pre-release programs for jails and prisons. So the last position that I had, we were like the direct connection for people coming right out of prison. And then we did have like a pre-release that they were still somewhat incarcerated, but getting ready to transition back into the community, and being able to prevent overdose using the Narcan or getting help. Some of the, like I said, some of these people that overdose and die, I don't believe they really intended that to happen, that it was something that, you know, they weren't aware of the dangers that could happen, and people that were there didn't get them help or know how to help. Can go to the next slide. And then there are alternative approaches. These are ancillary support services to active and former drug users. Some applications could be acupuncture programs for detox and relapse prevention. There is research that shows that that is very effective. It is also good for medical problems, massage therapy, Reiki, and nutrition information. There is a lot of new nutrition information coming out that's very good in providing this information in your treatment programs to help our clients understand, that nutrition is very important to their recovery as well. And then looking at our cultural, our beading, our drumming, our shawl making, our dancing, our singing, our sweat lodges, our ceremonies, having our elders involved. Go on to the next slide. Then we have the education model. This is the prevention of drug-related harm. This is to increase the awareness of harms of drug use through educational forums, drinking and driving campaigns, binge drinking reduction strategies. This is a picture of some IV drug use paraphernalia. So let's talk about addressing opioid use in our communities. In the Native context, communities may harbor negative judgment towards people who use drugs. Service providers may have negative judgments and biases, both personal and professional. Individually, we might feel embarrassed, angry, frustrated, and hopeless when thinking about the negative impact substance use has had on our people. As a result, we may choose to just ignore the reality of the situation. And we can't do that anymore. We can't ignore that. We really need to highlight this and do what we can to intervene and help the people that really need it. This is a reflection. Most of us didn't learn how to ride a bike the first time we tried it. It required support, practice, patience, maybe some training wheels. As we learned how to ride the bike on our own, we knew we were going to crash. But we also learned to pick ourselves back up and have the courage and determination to, keep trying it until we got it right. We had to take some risks to learn how to ride that bike. On an individual approach, we as providers need to work from a strength-based perspective as opposed to a deficit model. We want to not locating the problem within the individual, not taking into account the individual's environmental skill sets, knowledge, access to, and etc. Pointing out the things that they're doing really well. Hey, you're here today. I'm glad to see you here. You made the good choice today to be here today. Well, hope to see you, on Wednesday, or, we'll tell them about things that are going on, or, are you going to come to that? Really acknowledging them when they're there and pointing out the things that they're doing well for themselves. Anything that we can do from a strength-based perspective is going to build their self-esteem and their self-confidence in themselves. So, we need to be non-judgmental. There may be multiple attempts to change. I've heard as many as some clients taking 50 times to finally, get maintenance and clean and sober in their life. So it doesn't happen right away. And then, this harm reduction may be, looking at these people of they're not going to use as often, or as much, and be more responsible when they do use whatever substance it is they're choosing to use. We as providers also work from a client-centered approach. This means the client's needs are met, not ours. We need to let them feel like they're in charge of the decisions that are made and the treatment that they're going to receive. This is meeting them where they're at, looking at their motivation, their drug use and sexual risk factors, again, in a non-judgmental way, looking at their strengths, are there inherent cultural, survival, spiritual, whatever it is that, gives them strength, that helps them to want to be a better person. So looking again at the individual approach, it is for our clients. Change is an incremental, invisible, lifelong process. So we got to remind our people that, because you completed the program, this isn't over. This is something you have to take these skills and apply them to your life for lifelong. And I've met people that are, in years of recovery that share, there's certain things that they continue to do for themselves that helps them. Did you go back on this slide? Okay.
Sorry about that, Avis. I was trying to respond to a chat and
Okay.
accidentally moved the slide back. Sorry.
Okay.
I think we're okay. We should be on slide 52. Is that? Do I have it right?
Okay. Yeah, we're getting close to the end of the slides here.
No, we're great. We're doing great on time. So.
Okay. Yeah. Great.
Yeah.
This individual approach is setting goals, being supported, and celebrating small successes, and the critical elements of behavior change. So reminding the clients, what is your treatment plan? What is your treatment goal? And, I tell my staff, give them a copy of that treatment plan so that they know what they're working on, or give them a sheet while they're in group so they can write exactly, what it is, their goal that they're working on for maybe this month, so that they don't feel like they got to get something done in a week. That maybe, hey, you have 90 days. These are your goals. Where are you at on this, and where are you at on that? And being mindful of those relapse slips, getting off track, that's a part of the behavior change. Some people are really hard on themselves. So I always have to tell them, it's okay. Even people that go on diets, we have slips, and we have to do the same thing and get ourselves back on track. Go to the next slide. Using that community approach, we want to rely on our community strengths, our self-determination, our spirituality, look at our healing practices. I have seen people achieve successful recovery by participating solely in our cultural ceremonies that we have. Looking at the connection with the past, some of these people are struggling with intergenerational trauma. So, that is another thing that, we need to be mindful of, working in tribal communities, of how that's affected, and educate our clients that seek our services about, how they can help themselves overcome that. Looking at our family and our elders, our elders are our most respected people in our communities, our holistic thinking of like, we're in this together. We need to all help these people and be there and have pride in our culture. And there's a lot of others that we can do. Getting users involved. User involvement in the planning, mobilizing, and implementation of services is critical for success. Programs must reflect the values, customs, and social norms of that target population. In other words, programs must strive for drug user and native specific cultural relevancy. Looking at the organizational approach, strive to provide services that are culturally affirming, beyond cultural competency to cultural humility, holistic approaches to wellness, and inclusive of spiritual, traditional, and cultural needs as well. And here's another organizational approach that, for example, you can have a timeline knowing that, these are the things you could do. May is the Hepatitis Awareness Month, which is next month. There's a needle disposal week the 11th to the 15th, so we could drop and stop, have events, can participate, referrals can be made. 19th, a National Hepatitis Testing Day. My program is going to have a healing and wellness community event, and we're going to set up a lot of booths and have some information there. And I've actually been asked if I would teach people about the dangers of opioid use and how to get help. Then there's a Hepatitis Day, World Hepatitis Day in July, and in August, there's the International Overdose Awareness Day. So, marking these, planning these out ahead of time, I was like, what is our program going to do to address these things? The organizational approach is targeting messaging as strengths, community-specific messaging and brochures, public announcements, radio advertisements, flyers, posters, and of course, social media. I have a young girl in my company that we know she does our social media for us, and she likes doing that. So we use her for that a lot. Lastly, in my experience, it takes just one person through community experience, limited resources, time and time again. It's that one person, the lone champion, who stands up and makes reducing drug-related harm a priority for that community. Thank you guys for participating in today's presentation. We can open this up for questions. I saw several comments and whatnot popping up in the chat, but it's really tiny and I can't read them unless I put my reading glasses on.
I've been trying my best to watch and make some comments, but a lot of great comments in the chat. But I think it might be easier. We do have a little time, so if there are questions or comments, Avis, if you're okay, we can open the floor maybe. And
Yep.
And if you have a question or comment, or we can have a discussion here in the remaining time we have. So thanks again, Avis. It was I really enjoyed that. And I'd like to open the floor now for questions or comments.
This is
Hello?
Donna. Oh, go ahead. Go ahead.
Oh, go ahead. Go ahead.
Well, I was just going to say, if somebody else has a question, or if they're thinking about it, one question I have is, if I'm wondering if anybody on the call on the webinar today has any experience in their communities with safe injecting sites and how that has worked, and did it go well? Did it I've heard about them, but I don't know personally of any tribal populations that have a safe injecting site.
Nobody. I know most of these are in like our large cities. And I know that's where a lot of this came from. And I do know that needles are being used in my community back home and back here, but as far as actually offering those types of services, I know we're not. And I'm like, why are we not doing that? You know what I mean?
I know there are some needle exchange programs, and I know, though, that federal funds cannot be used to purchase syringes, but a safe injecting site where there's always going to be somebody there who has the Narcan and things like that. But I know Ben had a question, so we can get to that.
Okay.
I think Brian had a question or a comment.
Oh, yeah. Hello?
Yeah.
Oh, Noah, hello. I'm Dr. Garcia. Enjoyed the presentation today. I'm doing some more research on the harm reduction and work in the community behavioral health department in the Chicago community and nationwide. I was curious, you mentioned that you're going to speak on the effects of the opioid use. Is that something that you're doing within your own clinic, or is it going to be one of these sessions?
We are going to have a community, like a health and wellness fair. And I'm new to this community. I haven't been here a year yet. And they had asked me if I would, do a talk for those that are interested in presenting on that. So that's where I'm going to do that. And I think they have another cultural event this summer. And I was called by some people to come and do the same thing, because from what I heard from the people that asked for the services, we think there's people in the workplace, and I don't think they know that they're addicted to opioids, or they don't understand. And we get a lot of referrals through our HR program to our program, and a lot of it, like I said, I'm not getting a lot of people, or either they're just not telling us, but I am hearing from the community and what people see and find, that there are needles in the community. So even though we don't have those offered, but yeah, I have been asked to, provide some information, some educational information for that. So I will be doing that myself.
Okay, yeah, well, enjoy the presentation today. It's good to learn more on the harm reduction. I know just having the support for the community and different ways of supporting, it's yeah, I enjoyed it. Thank you.
You're
Ahoy.
welcome. Thank you.
Say, Steve, I just like make a couple comments. I know, and answer your question. Let's see, you mentioned Donna. I know when they had a kind of a needle exchange here some years back on Blackfeet, and you're right. IHS could not buy the needles, so at that particular time, I was director of Crystal Creek Lodge, and in one of our meetings, I asked my boss if we go ahead and give the IHS, believe it or not, some money to go ahead and purchase these exchange of needles, to come back and because they were finding them all over, the skating parks, and they can be, and like Avis alluded to it, kids can pick those up, and you never know what coming. It's this becomes a rolling ball after that. But yeah, we did do that for as far as those needles. That worked fairly well, but it is as fast as it came, it disappeared. I don't know what happened after that, but I think it's a great intervention and harm reduction that Avis had talked about, and some of those things there. And as far as the opioids, the tribe just recently, Blackfeet tribe, passed a resolution regarding the opioids, where the fentanyl especially it is way out of control up here. I think when it's a 2-week period, we had like about 17 overdose attempts. And so they just also formed in that particular resolution a fentanyl opioid task force. But again, they appointed a couple of people. I think that's where, and you mentioned, Avis, it's a community problem. So I think they should have looked at the array of the resources out there instead of just pointing to from the tribal health, to kind of look at some of the other people and point those kind of people on a committee. Because again, at Blackfeet, we have like outer line communities. We got Browning, which is the hub, but they're forgetting about the outer line communities. You need a totality of all these people, not just one area. If it's going to be successful, you got to include like Heartbeat, and Dan was here for many years. He could probably allude to some of this stuff here. That we got to include all these folks, and just like they're being left out. Period. I mean, I've been seeing this for a lot of years, and I know at one time I ran for council, and one of my part was, and I was going to test the sovereignty. We got about 3 entranceway into the Blackfeet country, and 2 on a border for Canadian border, and then we got west, east. Now I was going to set up see if I can, you know how they come through and check bears like you do in Canada and everything, but to set up a check station for everybody coming in and ensuring that they didn't have any alcohol, or I mean, not alcohol, well, alcohol too, but primarily these drugs. Because I mean, like I said, now it's just overrun. I don't know if it's been on the news here, but you know, we have several people arrested up here, and it's probably being national news sometime here. But anyway, it's like I said, it's overrunning here. And I warned the council, you know, many years ago. I said, you know, we had years ago we had FAS, FAE. You mark my word, if we don't do something about this, it's going to be worse. And lo and behold, I mean, I could see that coming. And I've been in many council meetings sitting there and say, I needed the support of leadership. And I had I talk about a module. I gave them a plan which included detoxification, right into treatment and coming back and transitional and trying to set up these various houses. But I didn't get any results. And I still have that plan. And like I said, I have pipe dreams, but I think it will become reality, but you got to be persistent. And like Ava said, you got to get out there to get the community involved. And that's what it's going to take. But it takes a few individuals to have the initiative, the drive, to go ahead and just never let go, continue on. And that was my big reason for running for council, because like I said, I was going to try to do all this stuff with the proper people. You can have all the right ideas, but you got to have the people in her to go ahead and back up your ideas to make it. And as far as I'm concerned, alcohol and drugs rule. There's no doubt about that. And that you talk about helicopters flying out here almost on a weekly basis. I'm venturing to say about 75% of all the medical and so forth had to do with alcohol and drugs. I mean, I don't think that's overkill. I think it's pretty straight.
Mm-hmm.
And now I think we just need to, in our area, not us, but as Native American people, we talk about sovereignty, and we had an attorney who goes on and gives talks about sovereignty, different things, and he does a great job on it. And so we need to get this done. And and I really enjoyed, Avis, I really enjoyed your presentation. I always enjoy your wisdom and all the good things that you bring to an Indian country. But I got to stop now, because I could talk for days on something like this, but I got to give you back to Stephen Davis. But thank you. That was just, my input. Thank you very much.
Thanks.
Thank you, Patrick. Always good to hear your voice. We've got a couple of other important folks on too that are connected to some of the work we do. Dr. Dan Foster is on, and I know Teresa Subril is on. They both, and Lena Gachapin is here. Looks like she's got an audience within her own facility there. So Lena, really great to have you on as well. Lena and Dr. Foster and Teresa are all consultants and advisory council that we work with. So we're happy to have you guys here. Doug, I see you've got your hand raised, so you've got the floor, sir.
I just wanted to say, in Oregon here, I know we got a good program in Portland. I just checked with NARA and they don't have a program, but Eugene has a program too. But I don't believe any of the tribes out here have a program. And he's right. We should flex our sovereignty and possibly try to get that going, because fentanyl has become really bad out here. We've had a lot of overdoses. So I just wanted to throw that in. And thank you for the presentation again, Avis.
Thank you.
Nothing in our rural areas, though. That's the problem.
I know something we might consider adding the next time we talk about this topic too is the fentanyl testing kits that are out there. There are pros and cons to those, but and they don't give you an amount. They just tell you whether fentanyl is present in your dose and can help, at least as a harm reduction perspective, notify the user that they may need to adjust their dose before administration. So, but again, there's also, the issue of a active IV drug user, being mindful and in the right state to consider these factors, knowing full well that there's some amount of fentanyl in the heroin that they're about to inject. So there's pros and cons to this. We get pushback on these issues in the treatment field all the time. Avis knows full well. It can sound like we're condoning substance use, and we're not. That's the thing I have to know. It's a balance between condoning and demonizing or condemning. And Avis talked about this, striking that balance and being able to adjust dependent on where the patient is. So thank you so much, Avis. And let's keep the floor open. We have a few more minutes. Yeah, Teresa brings up a great point too. And I speak to this all the time, that the substance use is not the problem. It's a symptom, whether it's heroin or alcohol or any other drug. Alcohol kills more people in this world than all the other drugs put together. And yet it's promoted, accepted, and widely available. And people don't drink because they want to die. They drink because they want to feel better and they have something going on. How many of you have asked your patient, tell me what you like about alcohol? It took me a long time to phrase that and see that as a very important question, because it opens the door for us to have a discussion about why they started drinking in the first place, and maybe address some of those comorbid issues. So it's something that I really think is a key if you're working in this field, is to explore those underlying issues. That's what's driving the use. I better be quiet. Like Patrick, I could go on and on. So
I know, like I said, I was getting carried away last night, and I was
we have Teresa. Teresa has her hand up, so I'm going to open the floor to her.
Miigwech. I really think we need to redefine our programs altogether in our Indigenous communities and departments and services. The statistics is showing what's been given to us isn't working, right? And to look at like what you guys are talking about today, and then incorporate what is our teachings behind that in our areas. So have a space for those who are struggling with sobering up, but at least they're coming in now. So keep them separate from those who are sober now, and then it's how we move in our teachings. You take this step and you go into your teachers, and then they send you out on your next step. You go back to your teachers, you go back to your next step. So creating those steps, but the tools that they need, so many of our people don't even know how to balance a checkbook, how to budget. The diet, as Ava's mentioned, I got so excited about. It is a huge factor. Dairy will almost immediately change your response, your chemistry in your brain. So to cater our diets to a healing our system diet, but make it budget friendly in our treatment centers so they can go home and actually implement this, make it as poor as possible, basically, but a healthy diet. And looking at smoothies as well, blending that food, because how many are coming in from the meth with no teeth or your pain in their mouths? But those smoothies can also, depending on what you put in them, food is medicine, help heal that liver, help heal those intestines, help heal that individual and their brain chemistry as well. So to teach them it and get them a part of that, so that way when they get home, they know how to do this. They know how to find, what do I need? What does my loved one need? So, and then what would we do in our teachings? We would send them out and we would tell them, okay, go and make your medicine. So on their outings, go home and maybe declutter and then come back to treatment. You had your day out, and they're making their medicine, they're making their bundle. So what are they going back home to? There's this clean space, this hope. They've been putting that effort into it, that medicine into it, that energy into it, you know, so making it a part of it and things like that, I think is so important. So I'm excited to hear about this. This is my first being so open to this, letting them use. I guess maybe I'm saying it in a horrible way, but not shutting them out for it. But be careful about what lodges you allow people to go into when they're still with those spirits, right? Because what that brings in the lodge. But I hope they understand that you're not being shut out. You know what I mean? Everywhere is lodge. Our life is lodge. So take them for that walk in the woods or the prairie or whatever your homelands is. And this is lodge. And when you get rid of these spirits, you get to step into the next part of lodge, a ceremony, right? But you meet ceremony until you're there. The other day I heard people really upset. They seem so hurt, and that is a hurt feeling when you think you're being shut out. But when you're coming with such a toxic attitude, you're not going to be able to receive. And those spirits coming with you may hurt those others in there, right? Or follow them back. To make that space, but be ready to deal with those spirits. Anyway, I can also go on. Miigwech for letting me share my thoughts. You can make a group to help to redesign, you know, something that would be effective. I'm in. Holler.
Thank you.
We're signing you up, Teresa. We're signing you up. Well, we are approaching the top of the hour. We've got maybe time for one more comment or question before we close. Any other questions for the group or for Avis? We're happy to take a question.
I just want to remind everyone that, like I said, this work is hard. It's sometimes it's draining, and we need to take care of ourselves as we help these people. So, you know, I just like to ask people, you know, what is the one thing that you do culturally that helps you to feel better and feel good about the work that you do?
That's a great note to close on, Avis. Thank you so much, everyone, for staying with us for this full presentation. Great to see so many familiar names and faces. And once again, Avis, you really knocked it out. So I really appreciate your efforts on this presentation. Thank you again, everyone. Until we meet again, stay safe, stay healthy, and stay connected. We'll broadcast first Thursday of next month, and we will have a really great presenter talking about healing and topics and issues related around Indigenous missing and murdered. So it will be a heavy topic, but a healing topic as well. So please join us for this presentation next month in our final broadcast of 10 here in our collaborative efforts with Bemidji IHS and our Native Center for Behavioral Health. Appreciate everyone. Tokcha. Take care.
Tokcha.